Managing zonulisis during phacoemulsification in the case of hard cataract. There are no financial disclosures. This is a case of hard cataract done by a younger colleague. She called for help when she noticed abnormal lens mobility indicating subluxation. After scrubbing in and evaluation of the situation, restaining of the capsule and enlarging capsular axis to decrease the tension on the zonules was done. You can see the area of zonulisis between 4 and 6 o'clock. Now the challenge, we have a narrow pupil, hard nucleus and subluxation. So first thing to do, if we decide to continue phacoemulsification, checking the nucleus and to see if is it possible to continue careful phacoemulsification in the capsular bag, adjusting fluidics so as to have a low bottle, low vacuum, low flow rate. And normally I do vertical chopping within the pupil in the bag. You should continuously observe nucleus movement and the capsule. During vertical chopping, always keep the traction during splitting of the nucleus toward the zonules to avoid increasing any degree of zonulisis. It's very important to observe the movement of the posterior capsule to avoid any further complications. Using vertical chopping allows you to work safely in a narrow pupil. As you advance in the surgery, you should use least phaco power to protect the corneal endothelium and to continuously observe the anterior and the posterior capsule and always have a backup plan. As successful chopping continues, the volume of the nucleus supporting the capsular bag decreases, and hence you can see increasing movement of the posterior capsule in the area of zonulisis. Once you see it's not safe to continue, stop. Think of a backup plan to achieve safe removal of the nucleus, avoid increasing zonulisis, and achieving implantation of the lens in the capsular bag. To stabilize the capsular bag, we can use capsular hooks that are going to be used here in the area of zonulisis. Capsular hooks stabilize the capsular bag and retracts the iris as well. It's important to place the capsular hooks in the right position and apply the proper traction. With a stable capsular bag, we can carry on phacoemulsification using vertical chopping in a slow motion fashion with low infusion, low vacuum, and low flow rate. Carrying on chopping of the remaining part of the nucleus, you should use least power to avoid insult to the corneal endothelium, and at the same time you should always observe the posterior capsule in the area of zonulisis. Observe here careful vertical chopping, slicing the nucleus into small pieces that needs least power. With the last pieces being removed, you should be extremely cautious not to injure the posterior capsule. Before removal of the phaco tip from the anterior chamber, viscoelastic should be injected in the same time to avoid forward movement of the posterior capsule. With almost no residual cortex, the capsular bag is filled with viscoelastic, and a capsule tension ring is inserted in the capsular bag to further stabilize it. Any remaining filaments or epithelial cells are washed off the posterior capsule with jets of fluid. With the capsular hooks in place, the capsular bag is filled with viscoelastic, preparing it for the intraocular lens implantation, and the lens is injected in the capsular bag that is now stabilized with the capsule tension ring as well as the capsular hooks. The lens is dialed into the capsular bag only with a filled anterior chamber with viscoelastic to avoid any stresses on the zonules. Once the lens is dialed in properly in the capsular bag, the capsular hook should be carefully removed and checking again the stability of the intraocular lens. After removal of the capsular hooks, check position of the intraocular lens and check if there is any vitreous strands from the area of the zonulisis. This is followed by hydration of the wound and intracameral antibiotic injection. Thank you for your attention.